Good evening, and Vinoy George from the Department of Nephrology. Thank the Scientific Committee of the Medicine Annual Conference for giving us this opportunity to speak on proteinuria for a physician's perspective. This is a brief outline of my talk, and I would like to conclude with some take-home pearls from a nephrologist as well. The patient comes to us complaining of seeing foamy urine, a term that was coined by Hippocrates. It was only in the 17th century the urine analysis began, and it was Richard Bright who had associated proteinuria with the kidney disease. It's a very common clinical finding. The causes of proteinuria can be diverse. It can be benign, and it's been associated with favorable prognosis. It can be due to orthostatic or benign persistent proteinuria. However, other proteinuриas which have sinister implications are transient and persistent proteinuria. Please remember, the urine microscopy analysis, which is a biological fluid, is equal to a liquid biopsy that provides a window into the kidney of what is happening inside. So what is the acceptable protein loss in the urine? When it comes to neonates and children, they have a reduced absorption, so they tend to filter a lot of more proteins in the urine, which tends to normalizes in the late childhood to adult levels of around less than 150 milligrams per meter square. The adults, the protein that is excreted, 15 to 20% is contributed to the albumin, whereas 35 to 40% is contributed by other plasma proteins and tam-horsfall proteins, which are secreted from the renal tubular epithelial cells. Now, the protein can be excreted due to an increased pressure due to diabetes, altered permeable selectivity of the glomerular capillary wall due to nephrotic syndrome. It can be due to a decreased tubular reabsorption or increased catabolism of protein as in sepsis. It can be due to plasma proteins that have been produced abnormally, which are excreted in the urine as seen in paraproteinemias or myoglobinuria. So how do we assess transient and persistent proteinuria? What test to order, which is the best? So patients with proteinuria, you need to have a complete medical history, a drug history. You need to look at the past laboratory studies, reports saying whether it's in the same lab or different lab. They need to be reviewed. You need to see whether it's a recent onset proteinuria or is it an ongoing proteinuria, and for how long. You should also look at the renal function to see whether it's a recent onset or whether it has been going on for a while, to know a time trajectory of the renal functions and proteinuria. Your assessment is not complete without a microscopic urine examination. There are 3 cases that are listed here for your interpretation. Case A is about a boy who had a fever who's come to you with a protein 3+ brought in by the mother, and an analysis shows an 850 milligrams of proteinuria with normal serum albumin, normal renal function. Second case is about a 17-year-old boy after an exhaustion from a marathon run. His mother brings him again with a protein 3+ RBCs at 10 with a normal creatinine, subnephrotic range protein of 900 milligrams, and rest are within normal limits. The third case is again a young lady with fever, lower urinary tract symptoms with 1,000 milligrams of proteinuria, with a protein 3+ RBCs 40, WBC 120. So looking at these 3 cases, definitely there should be some anxiety whether the patient is having a glomerular disease or whether it is something that is significant or not. So what is actually the next step that you do? You will give a battery of tests or just refer to nephrologists. My simple suggestion, if you have a history like this, wait and repeat the urine or blood and try to answer to all these questions that are coming up in your screen right now. There is a concept of an entity called transient proteinuria. How do you look at it? A transient proteinuria which resolves spontaneously after the reversal of the causal factor, as mentioned in the other cases. What is this test that you will repeat? Quantification of proteinuria and urine analysis need to be done. Please always do a renal function. When you repeat the test, urine samples with 1 to 2 weeks apart on 3 separate occasions, a negative dipstick with a resolving proteinuria or a normal creatinine, you can be reassuring that the patient and to yourself there is nothing to worry about. Case D is a young boy who comes in with, got an admission to CMC for medicine. On a medical checkup, he's noted to have a protein dipstick that is 3+, RBCs are nil, normal albumin. He has done these tests twice outside. On one, it was negative, the other, it is secondary. These kind of situations, if you are faced in, always try to rule out an orthostatic proteinuria. It's a very benign condition. However, it is something that is commonly missed and can be overdiagnosed and can harm the individual as well. So you need to rule out orthostatic proteinuria by doing a 24 urine collecting urine in 2 different jugs, what is known as a daytime urine jug and a nighttime urine jug. I've just listed out the procedure how to do it. A proteinuria that resolves after a supine standing in the nighttime urine sample is what is usually known as an orthostatic proteinuria. I repeat, you send both the jugs again for the lab analysis, and you have a proteinuria when the patient was in a standing position, that is the daytime urine samples, that has resolved when patient has been lying supine, which can be picked up in the nighttime urine jug. It is usually noted to be said orthostatic proteinuria. Alternatively, a normal urine protein creatinine ratio of less than 0.15 milligrams in the first morning spot urine specimen, when compared to those of a second upright urine specimen, is usually noted to say you are having an orthostatic proteinuria. So it is present in 5% of the adolescents. An increase in protein excretion in the upright position, which normalizes when this patient is recumbent. As a rule of thumb, excretion of less than 1 gram in 24 hours in the upright position, which usually normalizes in the supine position. It has got an excellent long-term prognosis, and usually it is not seen after the age of 30. So after we rule out transient proteinuria, orthostatic proteinuria, let's look at the pathological proteinuria that would come. You see a 21-year-old lady with fever going on and off for a year, pedal edema for 15 days with systemic symptoms. You have a urine analysis which says protein 3 pulse, RBC is 40. What is the next? And you see you have a proteinuria which is about 2 grams. So it's about 2000 milligrams, but you have definitely systemic symptoms. Here, you should try to rule out persistent proteinuria. You can go what I said with the urine samples 1 to 2 weeks apart on 3 separate occasions. But if you have an abnormal renal function to start off with and you see an increase in serum creatinine, I don't think you need to wait to do it on 3 separate occasions. In addition, you have a supportive urinary microscopy which shows abnormalities such as what I've listed below. You are dealing with a glomerular diseases which needs to be referred at the earliest. Associated symptoms, young hypertension, systemic symptoms with blood and protein in the urea, blood and protein in the urine, you're dealing with a glomerular disease. So what are the acceptable normal ranges for proteinuria? When you look at a 24-hour collection, urine albumin excretion, I have listed out the numbers above. On the right-hand side of the slide, you see that I have put it in corroboration with the 24-hour collection. Different labs use different parameters and different normal ranges, which you all should be aware of to interpret these tests. So this is with albuminuria excretion, and when you look at albumin excretion per rate, these are from mild to moderate and severe. These are the values that you need to look out. So severe, you say more than 300 milligrams of urine albumin excretion rate, or an albumin excretion ratio of more than 300 milligrams. These are terms that can be confusing, but these are how they go together. But when you look at a spot sample, it refers from the gender, and you say macroalbuminuria in a male of more than 200 milligrams of an albumin creatinine ratio, and a female of more than 300 milligrams. So what is the test to order? Which is the best? The qualitative, definitely the dipstick is the best. Good specificity, limited sensitivity because it cannot pick up the immune globulin light chains. You can have false positive and false negatives, which you are all aware of. Remember, negative dipstick with a quantification that is positive is significant of a tubular or overflow proteinuria. The other less common qualitative test, yes, we do see routine urine saying 1+, 2+ that you see on the left-hand side of the slide. The corroboration when you're not in a position or you do not have the facility to do a quantification of proteinuria, remember 1+ contributes about 30 to 100 milligrams, whereas a 4+ contributes to more than 1 gram. Now, quantitative, which test to order? Do you want to order urine protein creatinine ratio? Do you want to order an albumin to creatinine ratio? Currently, these tests are preferred over the 24 urine collection because of the greater convenience to do the test. Having said that, remember, 24 urine collection is the gold standard. There are some points to remember in the quantitative analysis of proteinuria. Let me take you through each one of them. The first, the strength of evidence is in when you measure urine albumin creatinine ratio or a urine protein creatinine ratio. It is as good as a 24 urine sample, but be aware of the accuracy of the test. You should standardize the protein measurements to the quantity of creatinine. The simple reason is because men and women excretion rate of creatinine is different, as mentioned here. So knowing the creatinine excretion, it will ensure you to say the collection is complete. The second, it will avoid errors to say whether it's a diluted or concentrated urine sample. The influence of age and muscle mass can be picked up if you have standardized your protein measurement to the quantity of creatinine excretion. So estimated and measured creatinine clearance are roughly equal and should be standardized. The third point is that the urine protein creatinine or the urine albumin creatinine ratio on a spot urine sample should be always corroborated with a 24 urine protein excretion in the first with it is always good. Fourth, the spot sample is more sensitive, especially the urine albumin creatinine ratio is more sensitive than urine protein creatinine ratio in detecting very low levels of proteinuria. Especially this role comes in diabetics and hypertensives. Dipstick is negative. You should do a urine albumin bar urine creatinine ratio or a macroalbuminuria should be checked. Urine protein by creatinine ratio is good if the protein excretion is more than 300 milligrams per day, and you can use this test longitudinally to see the therapeutic benefits of reduction in proteinuria when a treatment is instituted. The fifth point to remember, a urine sample is less robust in pregnant women because of the significant diurnal variation they have. And in the presence of a nephrotic range proteinuria, a spot sample is not useful at all. The sixth, when compared to a 25 urine sample, a microalbuminuria spot sample has a very good specificity and a very high negative predictive value. When it comes to protein creatinine ratio, again, the specificity is about 89.3% with a 96.2% negative predictive value. So it is good when it is used appropriately at the right time. Which sample to collect, if you ask me? I would, as I said, a 24 urine collection is always good in the first visit along with the protein sample, provided you advise them how to do it. Most of the time, the advice given to collect the 24 urine protein is wrong. I've just listed it out, and for the lack of time, I'm not explaining that in detail. However, my only request to all of you all is make sure you correct the urine albumin or urine protein to the urine creatinine excretion. What are the implications of proteinuria? It has two, on the cardiovascular and the renal. Most importantly, the recognition of proteinuria is important. Most of the time, we only look at the creatinine. We miss the urine analysis when a patient has been having a protein that is dipstick that has been positive 2+ to 3+. The reason is microalbumin is subclinically, it can be increased urine albumin. 5 to 10% with hypertension, with no diabetics and renal failure can have that. And it can be an increase in independent risk factor in a general population, 40% with microalbuminuria versus 22% who do not have, and patients with or without diabetes or hypertension. It can be a risk factor for coronary artery disease and can contribute 29 to 50% as proven in different studies given below. In renal, proteinuria is an independent risk factor for chronic kidney disease. It signifies a progression of kidney disease rather than being a marker for glomerular dysfunction. It is significantly has a high mortality predictor when it's seen in critically ill patients. The degree of proteinuria is very important in the post-renal transplant center because it's a predictive factor for graft and a patient survival. Reduction of proteinuria in a pharmacological treatment, it marks as a surrogate marker in the management of CKD, especially in acute glomerular diseases. For those who have not been listening or looking at my slides or listening to me till now, please look closely at this one particular slide. This is very important. The left-hand side gives you the classification of chronic kidney disease using the eGFR and the albumin creatinine ratio categories. Albuminuria is an independent risk factor for the progression of chronic kidney disease, and we should not miss it. The simple reason is this. Someone with a very high GFR or a normal or a high GFR can have protein leakage happening, that is A3. So increased levels of albuminuria with a normal GFR is something that we should not miss. Having said that, someone with an abnormal GFR or a low GFR can also have normal to less albuminuria. So when comparing the both increased levels of albuminuria with a normal GFR versus someone with a mild reduced GFR with normal albuminuria, it imparts a greater risk for a progressive CKD. So please be aware of this entity when you're looking at proteinuria perspectives. Persistent proteinuria, please refer it to a nephrologist. The impact of what, as physicians, that y'all can do, if y'all could focus on proteinuria reduction, y'all can slow the nephropathy progression. It has significant impacts on public health perspective, especially in diabetes and hypertension before the CKD sets in. So it can be used as a screening tool to pick up undiagnosed CKD. It can be an early predictor to tell us of a progressive renal function, especially in type 1 and type 2 diabetes. Screening for urine albumin, creatinine, even if dipstick is negative for proteinuria, is important. Individuals who are at risk for cardiovascular disease and chronic kidney disease, you can be picked up very early, especially in diabetics and non-diabetics. Presently, we wait for symptoms of CKD to happen, and that is too late. So reduction of protein in CKD, if you're not able to bring it back to at least a more than 30% of baseline reduction in the first 6 to 2 months of a treatment under your care, can definitely impact the long-term outcomes of renal and cardiovascular. How do you manage the proteinuria? You target the renin-angiotensin symptom. Can we use it early, and how early is early? Whether combination is good or monotherapy is good, is are certain factors that should be kept in your mind, and let me take you through them as well. So how early is early? Whether we start a normal albuminuria or when it's progressed to micro or macroalbuminuria, my simple suggestion is earlier you pick up, the better it is. Screening is important in general population, especially for diabetes and hypertension. The main goals in management is to preserve the renal function, blood pressure control, proteinuria reduction, reduce the adverse effect of drugs, and prevent the development of chronic kidney disease. The management of proteinuria when it comes to non-diabetic versus non-diabetic proteinuria, AC inhibitors slows the renal disease progression. It's especially useful in mild renal insufficiency and those with high proteinuria. Benazepril was the first initial drug that came out. It reduces the risk of end-stage renal disease with CKD and proteinuria, and this was substantiated with the RAIN study. Certain races do not use AC inhibitors in African Americans or in the Caucasians. ARBs have similar renal protective effects. It came out in the SMART trial, the RAIN-2 trial. Some other drugs that came out was the calcium channel blockers, the non-dihydroprotein calcium channel blockers such as diltiazem. Mineral corticoid receptor spironolactones, very commonly used as a cardiac combo. Be aware that hypokalemia is one of the most important effects. So AC inhibition, along with a low sodium diet and diuretics, play a major role, and of which salt restriction is one of the most important factor that plays. 3 to 4 grams is what is advised. So patients with proteinuria more than 500 to 1000 milligrams, you can use either ACE or ARB. Hypertensive patients with non-proteinuric, non-diabetic CKD, if they have edema, add a diuretic along with the RAS inhibitors. If there's no edema, use RAS inhibitors as a first-line therapy. Your goal should get to less than 1000 milligrams per day. A minimum reduction in proteinuria of at least 50 to 60% from the baseline values, plus a protein exchange of less than 3.5 grams is what you need to aim for if you're not able to achieve the goal. Diabetic proteinuria, again, RAS inhibition, majority of the studies and trials are being done in type 2 diabetes. ACE inhibitors were in type 1 and ARBs for type 2. There is no reason to believe that these classes are not effective in both the diseases. Its efficacy for blood pressure control and proteinuria reduction is similar. Whether ACE inhibitor or ARBs are more beneficial, in addition to both of them, dietary protein restriction, that the low protein excretion in diabetics in patients with microalbuminuria is definitely beneficial. So, which is beneficial? What does the evidence say? So, when it comes to preservation of renal function and blood pressure control, early initiation is of much benefit. ACE has been proven in the CAPTRIPLE in the UKPDS study. ARBs such as losartan has come out, and irbesartan has come out, the INT and Renal trial in type 2 diabetics. The conclusion was the remission or recognition of protein type 1, aggressive control of blood pressure with the ACE inhibitors was beneficial. And when it comes to type 2 ARBs, there was no significant cardiovascular mortality reduction or event. However, when it comes to renal outcomes, there was the reduction of 25% of doubling of plasma creatinine, the development of end-stage renal diseases increased if it was not used, and death from any cause was about 20%. The blood pressure control depends on the method of measurement. However, high-risk individuals who have stroke, peripheral vascular disease, atherosclerosis, or proteinuria, these are the standard blood pressure cutoffs that you should keep. Whereas a low-risk patient, the blood pressures of 130 to 139 and less than 90 millimeters of mercury in routine clinical office measurements is advisable. Non-routine measurements, home BP and ABPM, do definitely play a role. The reduction in proteinuria is ACE or ARB good. Both have been beneficial. You can use either one. The proteinuria goal, I said, should be aimed to less than 1 gram. Now, preferential renal protection patients with diabetic nephropathy, ACE inhibitors or ARBs are beneficial, either one of them. But always remember a point: type 2 diabetes and advanced kidney disease tend to progress relentlessly to end-stage renal disease despite treatment with ACE inhibitors or ARBs, provided they are not exposed to it. What about combination of ACE and ARBs? This was supported by the detailed trial. And with this concept, they decided that a combination therapy would give you a much more effect than monotherapy. However, the renal outcomes and adverse effects was well noted. And what they noted was the most common adverse effects such as hypertension, hyperkalemia, and no improvement in the outcome. In fact, there was an increase in end-stage renal disease, and doubling of creatinine was higher. Combination therapy has not been advised now. The only area where we use a combination therapy is IgA nephropathy. There was no similar outcomes noted in cardiovascular outcomes as well. So when you start on ACE or ARBs, please monitor the creatinine and the potassium for 48 hours, 7 days, and 14 days. Persistent, consistent increase in creatinine more than 30% of the baseline creatinine of the patient, not the lab reference, the baseline value of the patient. You should stop the ARBs. Or if there's a persistent, consistent increase in potassium more than 5.5 milliequivalents, check for the combination of drugs that are there, such as diuretics, statins, and accordingly ensure a protein-restricted diet, correct the bicarbonate if less than 20, and change the drugs if needed. These are the advices that I would suggest before you stop on ACE or ARBs. So how frequently should we do the test? So it is cost effective if you do screening to detect microalbuminuria followed by appropriate treatment of positive individual. Is it cost effective? Yes. So combining a dipstick with a urine for microalbuminuria outweighs the difference in the prevention of end-stage renal disease. Just a urine test, it can be given directly to the lab. Cardiovascular events can present much earlier than chronic kidney disease, so screening is important. How should a patient with a microalbuminuria be monitored in the long term? For diabetics, they say annually. I would prefer 6 months. In non-diabetics, there is not enough data. They say once in 3 years, but I would suggest you please screen them annually. How should a patient microalbuminuria be monitored in the long term? The limitation using only the urine protein creatinine ratio to follow protein excretion. Always obtain a 24 urine protein and a creatinine excretion during your initial evaluation. Compare the values. Subsequently, then you use a protein creatinine ratio, which will be more accurate, which will give you the estimate the degree of proteinuria. When you refer for diabetic kidney disease, referral should be a multidisciplinary onset of microalbuminuria and Those patients who do not fit into the natural progression of diabetic kidney disease, please refer it to the higher specialty. 80 to 85% can still be diabetic nephropathy, but we need to rule out non-diabetic renal disease, which can contribute 15 to 20%. So some of the clinical pearls that a nephrologist wish every primary care physician knew so as to avoid common pitfalls such as late recognition and late intervention, or to help you all to guide in a decision, it's good to refer to the specialist. So the next subsequent slides will give you 10 plus 2, 12 pearls. The first two pearls are a normal serum creatinine level may not be normal always. It depends on the muscle mass, height, and it can also affect in a patient with limb amputation. So a patient with an amputation and a high normal creatinine level can be already having an advanced CKD. Know the medication that spuriously elevate the serum creatinine with no changes in urea, such as Septran, cefoxitin. An increase in creatinine can show a true decrease in GFR. Only corresponding increase in BUN levels will be noted. The third is patients with decreased GFR or protein should be evaluated to determine the cause. In patients with early stage chronic kidney disease, periodic evaluation intervention is needed. Avoid its complication. Use ACE or ARB, which is better. Monotherapy is good, not the combination, as I said, except in IgA nephropathy, we do use them. I still use losartan, which is an old man's drug. It's cheaper and has stood the test of time. Do not automatically discontinue an ACE or ARB slowly because of a small increase in the serum creatinine or potassium level. Remember when to stop, follow these guidelines. Anemia in patients should be treated with erythrocyte stimulating agents. Please refer it to us. Do not overtreat them, but maintain a target of 11 to 12 grams. The seventh is phosphate-containing bowel preparation should be used with caution in CKD. Acute phosphate nephropathy can cause significant fluid shift and electrolyte abnormalities. Risk factors such as inadequate hydration, increased patient age, use of concurrent ACE or ARBs can aggravate the situation. Patients with severe CKD should avoid magnesium or aluminum-containing oral preparations because concomitant use can precipitate them to acute aluminum toxicity. Most patients with hypertension should be screened for secondary hypertension. Certain clinical clues may suggest the presence of an underlying cause, and if addressed, it can be resolved or it can improve the hypertension to better. Endocrine causes should be considered. Renal, worsening of blood pressure after starting ACE or ARBs, young hypertensive, active urine sediments with proteinuria. Assessment of target organ damage should be done as well to reduce the cardiovascular risk. In patients with recurrent stone disease, in-depth metabolic evaluation is actually needed to prevent further episodes and also to promote stone dissolution. Refer to a nephrologist or urologist. So early referral to a nephrologist should be considered if there is a progression of CKD, uncontrolled complications, uncontrolled blood pressure, uncontrolled secondary hypothyroidism, active urine sediments such as in RBCs. Immunosuppressive drugs usually used more commonly in renal allograft recipients and in GNs. Please, I'd like to highlight the importance of doing a therapeutic drug monitoring when you're using these drugs for its beneficial effects, especially to maintain an adequate therapeutic level, to treat the illness at the same time, not to predispose them to infections of over-immunosuppression. Always remember they have many drug-to-drug interactions which can increase or decrease levels, which can be determined for the graft if it's in a transplant and for a patient in a non-transplant setting. So be careful to review with drug interactions that can also alter these levels. To conclude, early recognition and evaluation of proteinuria is important. Appropriate treatment and referral is necessary. It's good to moderate so that we can reduce the morbidity and mortality that is affecting the diseases of the kidney. So practice medicine wisely and honestly, and thank you for giving me this opportunity.